Good morning, everyone. Thank you for giving me the opportunity to present to you my topic about mitral annular calcification, clinical implications and surgical perspectives. I sincerely thank the organizing committee, on top of which Dr. Rahman, for giving me the privilege of talking to you this morning. So mitral annular calcification, otherwise known as MAC, is a chronic degenerative process in which the mitral valve fibrous body is involved with calcification. The prevalence increases with age. It's estimated to be anywhere between 10 to 15% of patients screened in a population-based study. Also increases in female gender, patients with chronic kidney disease, and cardiovascular risk factors. Clinical significance spans the cardiovascular diseases, arrhythmias, and surgical outcomes. So a brief explanation of the fibrous skeleton of the heart, where there is a fibrous body continuity involving the mitral annulus, namely part of the posterior mitral annulus and sparing the P2 area, the aortic valve annulus, and the tricuspid annulus, where the right trigon meets the membranous septum at the commissure between the right coronary and the non-coronary commissure. This is called the central fibrous body, and we have the aoromitral continuity. Typically, mitral annular calcification involves the mitral annulus and the posterior mitral annulus, to be exact. Now, the implication of this surgically is significant because a lot of the significant and vital structures related to the heart are close by. Remember, the mitral valve is a part of the left ventricle and the left atrium continuity apparatus. Also is intrinsically related to the aortic valve, the conductive system, bundle of His, and the left circumflex. So understanding the anatomy clearly is paramount in order to perform successful decalcification and reconstruction in this very sensitive area. And as you can see here, this is the posterior mitral annulus, where the hinge between the left atrium and the posterior mitral leaflet lays, and the MAC, or mitral annular calcification, the left ventricle, and you see the close proximity of the left circumflex at the epicardial portion of the myocardium. So, performing careful decalcification and reconstruction is important, and it is even more important to understand the relationship of the anatomy to these vital structures. The pathophysiology of MAC is ill understood up until this time, and the risk factors for development of mitral annular calcification are primarily the traditional risk factors we associate with cardiovascular diseases, including diabetes, hypertension, old age, smoking, etc. But also, on top of that, there is some theories that speculate that the stress on the mitral valve, which we know is a bit higher than the other valves, at least when compared to the aortic valve, because of the differential gradients in the mitral between the left atrium and the left ventricle, induces a huge stress on the valve. And with hypertension, for example, this can cause damage, injury, inflammation, and later necrosis and calcification. And also, some of the postulated mechanisms for mitral annular calcification are abnormal calcium phosphorus metabolism, such as in chronic kidney disease and primary tertiary hyperparathyroidism. The clinical manifestations in mitral annular calcification, typically it is asymptomatic. It is discovered as part of the workup for something else, such as coronary disease, mitral valve pathologies such as mitral stenosis or regurgitation, and aortic valve replacement. But again, it has significant implications, especially when intervention is intended on the mitral valve. But it can also present primarily as primary mitral stenosis or regurgitation, arrhythmias, especially atrial fibrillation, and infective endocarditis. The diagnostic modalities for mitral annular calcification typically are chest X-ray, especially the lateral chest X-ray. It's not clear, but it's not the best, but it can give you a hint that there might be a chunk of rock of calcium sitting behind the heart. Echocardiography is a key tool in identifying the mitral annular calcification, but again, it's not specific in giving you an impression of the extensiveness of calcification, or at least the visualization, the full visualization of the calcification. CT, with or without contrast, it tends to be the gold standard for accurate quantification of and diagnosis of mitral annular calcification. Also, other scoring strategies such as Augustin's scoring system can be added to help verify the extensiveness of the mitral calcification. Also, mitral annular calcification can clearly appear on coronary angiography. And severe MAC is defined as more than 4 millimeters of thickness plus more than 50% in annular involvement, or a chunk of calcium protruding on the LVOT. And this is an example. I'm not sure if the pictures are clear here, but you can see at the top panel the extensiveness MAC on coronary angiography, and again, the visualization of the same MAC on echocardiography and ultimately CT scan, which clearly gives a visual impression of the extensiveness and the amount of calcium involved. So the MAC and the implication of MAC clinically ranges on a huge spectrum, and severe MAC can cause mitral regurgitation, restriction of the posterior mitral leaflet, as explained earlier, and the pathogenesis include restriction of the leaflet mobility, which can lead either to regurgitation or stenosis or a mix of both. Now, for us as surgeons, the importance of MAC comes in its surgical challenge. Especially as surgeons, we clearly appreciate that calcium is impossible to sew in. And in order to successfully reconstruct or perform any surgery in an area that is calcified, full decalcification and reconstruction of that missing area is important, which again leaves the challenge. Plus, added to this, that mitral annular calcification does not come in isolation. Usually it's a part of a spectrum, whether the atherosclerotic load, calcification load such as porcelain aorta, coronary calcification, peripheral vascular disease, and history of stroke and predisposition to stroke perioperatively. So these all have to be taken into consideration when assessing somebody for mitral annular calcification prior to surgical intervention. And the management of mitral annular calcification as a primary pathology ranges from just conservative management and observation and medical optimization to transcatheter mitral valve, either repair or replacement, surgical options, which we will discuss a few of them in the coming few slides, and the most important is a tailored approach to reduce the risk of complication and optimize outcomes. A few years back, we authored a paper named Brain Before Heart Strategy for Coronary Artery Bypass in Severely Atherosclerotic Aorta, basically porcelain aorta. And I think the approach for the mitral annular calcification is no different when it comes to the assessment. Now, the number one factor, or the number one criteria in our algorithm, is first of all preoperative assessment and preemptive intervention, meaning you really need to make sure that you have the right diagnosis, that you've identified mitral annular calcification prior to taking somebody in the operating room and opening his or her chest, because this will allow you to go through an exercise of deciding which is the best tailored approach for your patient, compared to suddenly discovering that and once you've opened the heart and opened the left atrium and lifted the heart up, to suddenly be shocked that your patient has severe MAC. So again, preemptive intervention is important, and this starts from taking full history, going through the imaging modalities and identification, and having a multidisciplinary team discussion. In some cases, conservative medical management might be the best outcome. In other cases, a hybrid approach. In some cases, a pure surgical approach, which is fully prepared for according to a specific algorithm, because as we know, typical mitral valve replacement was just debriding the leaflet and taking annular stitches will not work and might lead to consequences. This is the most commonly practiced approach, an approach that I advocate and I have done many of. And when it comes to the decision to operate on the mitral valve with MAC, then a good exposure of the mitral valve, as we do with any mitral valve. Number two is full debridement of the calcium from the posterior mitral annulus. Now, once that is done, then you've exposed the epicardial portion of the sitting behind the posterior mitral annulus, and that epicardial fat will harbor the left circumflex, as you can see here. So it is crucial at this point is to sew in a patch, either a autologous pericardial patch, a bovine pericardium, or sometimes flipping over the anterior mitral leaflet on the posterior annulus, taking good bites in the myocardium, ensuring that the posterior suture line of your patch takes good bites in the myocardium to secure the patch. Because again, the only thing will be holding your valve, and later on when the heart starts beating, holding the AV groove, the atrioventricular groove, is this patch. So this patch has to really be solid and stand. So once the posterior suture line is done, then pledgets for anchoring the mitral valve prosthesis are inserted underneath the patch, making sure to take a lip of myocardium in the lower suture line. This will secure your pledgets under the patch. And the reason why you want to put your pledgets under direct vision under the patch is to avoid the left circumflex if you take them blindly, or you put your pledgets after sewing the patch and closing that defect. So again, I think the best approach is to carefully do your posterior suture line on the patch, and then put your the anchoring pledgeted sutures while taking a small lip of ventricle or myocardium on the posterior suture line, and then flipping over your patch, closing the patch. I typically use either 3O or 4O Prolene to sew in the patch, and then anchoring your valve, as this clearly shows in this example where we have severe mitral annular calcification, clearly evident on this left atrial approach view. And then once the calcium is debrided and cleared, I mark the area where the defect is in order allows me to get a visualization as I'm sewing the patch, not to get lost inside the ventricle. Again, remember, there's no more annulus, and you might, as you're sewing the patch and things are very tight in that area, you might get lost. So again, marking the defect with a marking pen allows you to identify where your suture line is going to be inserted. And then tailoring a patch, again, put a generous patch. You can always downsize the patch as you're progressively sewing inside the ventricle. And then once the patch is anchored, then I place my anchoring sutures underneath the patch and finish the patch closer, as you can see here, and then anchor the valve as you would do with any typical mitral valve replacement. So again, this is, I think, the most commonly and safest approach. It doesn't work for all patients, but again, for patients especially who have posterior mitral annular calcification, I think this is a great approach. It can also be used in the setting of mitral valve repair, where you can detach the posterior leaflet where the calcium is, debride that area, sew a patch, put your anchoring stitches, and reinsert the posterior mitral leaflet in that area. Again, that has been done, and I've done it, and I'm sure some of you have done quite a few. Another alternative, if the calcification extensive, is using TAVI valve, transcatheter aortic valve replacement, depending on whatever company you prefer, preferably an inflatable valve. And after taking out the leaflet, pledgeted sutures are inserted in the rim of the valve along the leaflets or the remnants of the leaflets, avoiding taking your pledgets inside the calcium again, because they won't pass, and then reinforcing that with overlapping Teflon film. What this does, it gives you a anchorage area for the TAVI valve to come in, and then the TAVI is inserted, inflatable TAVI, through a balloon, through a catheter and balloon, and then interrupted stitches are done along the edges of the TAVI valve to secure it in place. This technique has been done, and it's quite popular, and seems to have reasonable outcomes. Again, these patients, you have to understand, it's not about replacement of the valve, it's about the comorbidities of these patients who usually come quite sick with multiple risk factors that can affect their operative outcomes. Another approach proposed in the 1980s for patient prosthesis mismatch in the mitral position is called the chimney valve. I've done a few of these also, where you take a valve conduit prosthesis, whether you sew it in manually, especially if you have a biological valve, or take a valve conduit prosthesis for a Bental root replacement, and trim the graft at least 5 to 1 centimeter above the valve. Again, you don't want that trim or skirt to be too long to avoid kinking of the valve conduit. What typically is done is the anterior portion of the valve conduit prosthesis is made short, meaning that the graft is short and that area is beveled. That because you want to sew in the anterior mitral annulus, if it's not calcified, you want to sew directly to the annulus. So you put your anchoring sutures on the annulus and you anchor them, you sew them as close as possible to the valve, or tie them close as possible to the valve. While in the posterior mitral annulus, what you want to do is take your pledgeted sutures in the leaflet, not in the annulus, because the annulus is calcified. And this what will give you a valve that is a chimney-like valve, suspended, or a floating valve in the middle of the left atrium. Again, you don't want that valve conduit or your graft to be too long, because this might kink. Now, what some other surgeons do is, I'm not a big proponent of this approach, is to sew another pericardial skirt along the proximal end of the sewing of the valve, or the posterior part of the valve. So in order to eliminate that chimney-like protrusion of your valve, so that the blood just directly hits the valve without swirling around the chimney. Different ways of doing this. Either you take once you've anchored the valve conduit into the mitral orifice, you take a skirt of pericardium and sew it around the valve between the sewing ring and the left atrial wall. Or what you can do, if you have a redundant huge left atrium, you can directly sew the valve and the sewing ring of the valve and the left atrial wall together. Again, I don't think this is necessary, especially if your valve conduit chimney is not too high.
Dr. Rakan?
This is the same approach can be done with the mitral, with a biprosthetic valve. And again, you take usually a Magna ease valve and sew it inside a graft that is 3 sizes above the graft. So, for example, if your valve is 25, then you want a 28 graft, and then like you do with a biological Bental, and then sew bevel your graft so that the anterior portion is shallow, the posterior portion is long, and anchor your valve, and you have a chimney valve. And you can see it clearly here that the valve is in supraannular position and is suspended in the middle of the left atrium. Now, other emerging technologies as we speak for treatment of mitral annular calcification is obviously catheter-based valve. TAMR is coming. Still in the experimental phase, I would say, but I'm sure within the next few years, we will see a prevalence of use of mitral valve TAVI or TAMR, as we did see in the aortic position. The use of 3D printing for surgical planning and advances in image-guided surgery. The complications and postoperative outcomes associated with operating on somebody who has MAC.
Just for the sake of time, this is a recorded
presentation. So
we'll just
neurologic
stop
insults
it at here.
are valvular leaks, especially if the stitches are
Then
not
we'll move to
taken.
the next speaker.